Well, actually, the military health system, so all of the services leadership and the leadership at Health Affairs, in concert with the rest of the medical establishment, is a recognition that most individuals come into the healthcare system for acute illness, and they may encounter the healthcare system 2 or 3 times in the timeline of a year. The rest of the spaces are what General Horoho and others in our leadership have called the white spaces. The spaces where we live every day and where our decisions and our behaviors determine our level of health in many cases. So the challenge of a healthcare system to address and develop programs that enter into those spaces between physical medical encounters that impact behavior that preserves or potentiates health. That's the current paradigm, the current challenge and focus of the military health system. And all of us who contribute to that, in our case it's immunization healthcare, where vaccines are one of the most powerful tools we have to keep people healthy, to prevent disease. How do we deliver those most effectively? Our military population has a mandate for vaccines, but our beneficiaries have choice. So how do we improve compliance with those vaccines that clearly can prevent disease, prevent hospitalizations, potentially prevent deaths? How do we get better compliance and acceptance of that? So our mission fits into that larger mission, whether it's preventing smoking or what you eat and you know, the grandmother things of, you know, enough sleep being critical to health, and people in our culture are ignoring that. Eating balanced, nothing in extremes. Thinking happy thoughts, right? What Grandma said, eating right, sleeping right, the golden middle way. How do we make that real for folks and show them that evidence-based medicine supports those choices, and we have a choice in really how much health we can promote in our lives personally and in populations, and how do we help people make the right choices. That's where that is. So we have right now in our population in the United States, but really globally, the challenge that we have these very powerful drugs, prescription drugs known as vaccines, that prevent diseases that had very high mortality and morbidity, meaning secondary consequences that impacted on quality of life. And the classic example is polio. Because the vaccines have been so effective on a population basis, most young people today, it isn't real to them that you could get polio, get paralyzed, end up in an iron lung to breathe and or die. And then secondarily, if you survive, you are disabled in terms of the function of your legs. That's a very powerful reality, that when that was happening in your neighbor and your friend and a family member, and suddenly we came with a tool, the polio vaccine, that could be prevented. So people were embracing it, and nobody really paid attention because the benefit was so clear and visible versus the risk, because any drug can have an adverse event. And with the oral polio vaccine, very rarely 1 or 2 children out of 1 million doses could actually develop a paralytic disease. But compared to the live disease, that was clearly so disparate. The pluses were much stronger in everybody's mind. Today, the pluses of preventing polio, even though polio is coming back in some parts of the world, aren't visible, so the fear of a vaccine having a side effect that could hurt you has become much greater. And the knowledge of how to balance those two things, the knowledge that we have a new polio vaccine that has a negligible risk. So the older polio vaccine, a lot of people don't know that we have a different one now that is even safer. And so communicating those pieces of knowledge in a balanced way that people understand is a challenge for nurses, for doctors, for the public health officials. And we don't have as much science education and medicine education in schools as we all would like. So that, and all the vaccine constructs, this is true. There's no free lunch. There's no such thing as 100% safe or zero. Those two things are, I always say to our students, those are lies. Even if you lay in bed and put your covers over your head, there's risk. And understanding that and managing risk-benefit ratios in your life for choices is where we are really in the 21st century. How do we reach everybody where they live and where they understand that becomes real, and what we would say is a balanced decision is made. The polarization of vaccine no, that group has strong beliefs and potentially personal experiences with adverse reactions. So every drug, vaccine or otherwise, has the risk in some people to produce an adverse event. In some cases, that adverse event is a coincidence. So if I was vaccinated yesterday and I go home and tomorrow lightning strikes me, there's a temporal association to those two events, but most people would accept that it's not reasonable to blame the vaccine for the lightning striking me. So illness happens at a certain rate. So when you immunize large populations, some people will get sick in time relationship to their immunization event. So then the question is that true and unrelated, like the lightning strike, or is it actually a more severe side effect or a clinical illness complex that really was triggered by the vaccine? And when these adverse events are very, very serious, a parent of a child that's been immunized or an adult who develops a serious neurologic disease like Guillain-Barré, it's natural to think, well, what happened just right before that? And maybe that's the drug that caused it. When we have clusters of cases that are similar, that raises the question, could a causal relationship exist between the immunization event or the vaccines and this cluster of illness? And there's we don't have time to go into the very complex processes that are being applied in the public health arena, in medical research, to try to differentiate that. It's not easy. We don't have the best tools for understanding rare adverse events, especially. So there is distrust, and when patients experience something that they believe is linked, their distrust spreads. So often when we see patients who have concerns about a vaccine, they've had a battle buddy or a friend, or personally have had a bad reaction that they believe is the vaccine. Maybe they had it multiple times and it got worse with each dose. So they're asking for answers about benefit risk. And because knowledge is not as clearly presented to doctors and nurses and medics and corpsmen in training, often they hear the mantra, vaccines are safe and effective, there are no serious adverse events. And that actually is talking about populations, that we don't have an epidemic or a forest fire of problems. It really doesn't address the fact that 1% to 2% of people who receive any drug may have symptoms after that drug, may not tolerate that drug, and may rarely have a serious adverse event, which it's hard to prove or disprove. And that's the struggle. And what's happened, as so often happens, there's a polarization of people who believe vaccines cause certain adverse events, and then the medical establishment that says, well, right now we don't have epidemiologic evidence that there's a link, and we really don't know in rare events, could it or not. So a recent Institute of Medicine report where they were asked by the Health and Human Services to review 158 vaccine adverse event questions. The majority of them, over 130, they classified as we do not have sufficient data to say there's an association or there is no association, which in layman's language means we just don't know yet. And that's the challenge. And my program, our program, the Vaccine Healthcare Centers Network with the Military Vaccine Agency, attempts to really carefully evaluate the individual patient, consider benefit risk, review the literature, and then try to do a plan that optimizes safety and efficacy. And I hope that gives you some feel. It takes me usually quite an hour talking to angry patients or their families to explain that, we are limited in our tools and our knowledge. And usually, when two groups get polarized, the truth is somewhere in between. And we're now on this very exciting journey of trying to, with newer tools, with immunogenetics, with vaccinomics, it's really new specialties. We're, I think, on a path to improved understanding, and in the future, we may have more personalized immunization healthcare. What is the best way to immunize you may be different from another person with a different gender, a different genetic makeup, a different racial background. As in the rest of medicine, we continue to learn that those chromosomal differences and the things that drive gender difference in biologic responses impact how we process the vaccines. And that's both for efficacy and for safety. And again, we're kind of just cracking, and I was very honored that the Jordan report, which the NIH does this report on the state of vaccines every couple of years, and we were privileged to, Dr. Claude and I, to write an article reviewing the literature on gender differences in vaccine responses. And it's really quite dramatic, quite interesting. It may have future benefits for if we can give a smaller dose to healthy young women than to men, then when we have shortages in supply, we can immunize more people. So, I think it's a culture change. Our past was one size fits all because we were trying to keep people alive from smallpox or polio. Now the public is demanding, and our approaches and our understanding is that we have to respond to those people who don't fit the one size fits all. So a colleague of mine said, so the one size fits all works really well for probably 80% of the population. But then we have these outliers, and personalized medicine is an attempt to begin to embrace in each scenario in medicine, whether it's with vaccines or other drugs, how to personalize to your responses. For our service members, when we mandate vaccines, and so it's a part of our service requirement, it's not a choice, which is unique for any other population, although there are pressures for children to be immunized but to be allowed to go to school. But for service members, it's part of their job. The intent of that is to protect them from preventable diseases when they deploy to what we jokingly say are non-OSHA approved environments. They're rough areas with lots of disease. And then also from bioterrorism agents, potentially, like smallpox or anthrax. So when something is mandated, we certainly have an ethical imperative when it's a medical intervention, a prescription drug, which vaccines are, that if they have a problem or a concern, that we address that and outside of a punitive environment. So whenever something is mandated, the trust issue, distrust potentially goes up. So our program actually grew out of a need to make sure that every service member and ultimately any beneficiary in our system, if there is a concern or an issue and they are not satisfied with the first response, that they have access to experts like my group at the Vaccine Healthcare Centers Network who can take some time to really address the question. And that's part of trust. So when folks come to us, they often say, well, you're the first group that actually took time to listen to my story. And that's not anybody's fault. Remember, our poor primary care doctors have to stay 3 to 5 minutes to see a patient, and they're not trained. They're not trained in immunology like we are, and don't have the most recent information. So when these issues arise, if we don't embrace the complex and that which requires more time, then people become angry because they don't feel like their concern has been addressed. Or if somebody says, well, if you don't take this vaccine, we're going to do a punitive action, but it's a medical issue. So those things I think we've done a good job to improve. But throughout the vaccines issues, it's always, if it's mandated as opposed to a choice, that potentially raises distrust, because as you know, the trust of government or establishments actually in the population about anything is kind of low. So, and then again, people don't see the good that it does. They don't see the prevention piece. And we have the job of trying to build trust through understanding of the facts and through acknowledging the things we don't know. So the way to build trust is you tell people what you know, you tell them what you don't know, you never make fun of their concerns. So if I go to the doctor and say, I had a flu-like illness after my flu shot, if that doctor says to me, well, you're just a woman having histrionics, or, you know, that can't happen, it isn't real, you're not really very bright, that makes me angry and distrustful. So we need to teach people to re-script their responses, to acknowledge that there are people who could have these syndromes. There may be ways we can manage it. So tell them what you know, tell them what you don't know, acknowledge their concerns in a respectful way, and then fourth, tell them what you're going to do about it. Work with the patient, work with the individual for positive solutions, win-wins, and understanding. That's, thank God, we need to build trust in a lot of areas. I think we're just, it's taken many years, but we have evidence that the Jordan Report, the National Vaccine Advisory Committee, CDC Immunization Safety Office, internationally the Brighton Collaboration, all of these initiatives are an acknowledgement that we have to standardize how we define a case as an adverse event potentially, so the world can partner in research. When you're talking about rare, a couple of cases, you know, per 100,000 or per million, the entire world using a vaccine needs to partner. And I see a movement in that direction. I see advocacy for support for clinical research in these post-licensure safety and efficacy studies that embrace biodiversity. It's still small, it still needs to grow. Dr. Cooper in 2009 in Newsweek, he was the former president of the American Academy of Pediatrics, former head of the Advisory Committee on Immunization Practices. He wrote to the fact that we have to embrace the two failures that are undermining trust in vaccines. The first is the adequacy of education of both healthcare workers and the public about the risks without the vaccine. Because actually the providers are some of the impediments, their attitudes toward the flu shot. They really don't educate the patients strongly enough of why it is a benefit potentially to them, while also not acknowledging the concerns. So that's a big area where the room for improvement is the largest room in the house, and everybody needs to be a part of that shared education. The second failure is adequacy of research support for understanding and growing the understanding of the biodiversity piece, characterizing a case definition for an adverse event. So if it's flu-like syndrome after flu shot, let's embrace that. Let's study it. Let's look at the ways we can prevent it or we can treat it. That builds trust because people feel respected, that their concerns are being addressed. And that's usually what people want from the healthcare system. Well, as I spoke in my talk, there's a lot of exciting technology evolving, and as an allergist, you know, we're seeing new vaccine mixtures with potentially allergens like grass pollen antigens, and the common cold antigen. So the definition of vaccine is clearly going to change and evolve. And HIV, as we all know, has been a many decades long battle. And at the start of that epidemic, where we knew nothing about the agent or how it interacted with the immune system, there was a lot of hope and arrogance that we would have a vaccine in 5 years, and now it's decades later. And many people a few years ago were concerned that the investment in vaccine, it just wasn't going anywhere. But I see hope. There were recent studies that showed they were able to characterize what kind of antibodies and what kind of cell-mediated immunity was most effective at potentially neutralizing the virus and virus spread. So there finally has been a viral construct, a vaccine construct that had 33% efficacy. So people might say, gee, 33%, it isn't very much. But it's a start. And we haven't had that kind of hope in a long time. And immunology, as a result of this tragic epidemic and disease, has advanced logarithmically. The knowledge, the complexity. And as we understand how an immune system defends itself, we are going to get better at making vaccine constructs that upregulate those defenses. And I have hope. I'm an old lady in my 60s, and I have hope that in my lifetime I will see a vaccine. Well, I always am grateful for opportunities to educate and give people a better view of the world that I see. So, this conference, it was wonderful because many people said, gee, that's a great new insight into immunization healthcare, that it's not just about tables of vaccines and giving vaccines without understanding their impact, both the positives and sometimes the negatives, and that we can manage those negatives, that biodiversity and gender differences acknowledged. So for me, the joy of lecturing and teaching is opening people's minds and getting them excited and making them understand vaccine benefits in the context of understanding all perspectives. That to me excites me a great deal. And I had great questions, and I think my goal is to make everybody embrace the good that vaccines can do, while understanding why some people are afraid of them, why some people are against them, and to join the challenge that I think we face in all areas, which is building those bridges of understanding, because the truth is always in the middle. And if we can get closer to the truth, then we'll do the best for the most people.